is on I picked the title The Science and Art of Management of Multivessel Disease in STEMI. هنحاول نركز على قد ما نقدر على السيرجيكال hybrid revascularization, which is really tricky. Why does it matter? ليه بنركز على multivessel disease in STEMI? Because almost half of our patients with STEMI have some form of multivessel disease. About 30% have two-vessel disease, about 20% have three-vessel disease, and around 6% have left main non-infarct-related artery coronary artery disease. And these non-infarct-related artery lesions are associated with poorer outcome. يعني they are prognostically relevant. Their pure presence dictates worse outcome. So how should we approach these lesions? Some may suggest that these lesions are non-active. These are stable lesions and should be treated as such, as chronic lesions. While others may suggest that these lesions are biologically active, more or less vulnerable, and should be treated as unstable ones. And when we compare these lesions in terms of vulnerable characteristics with the chronic stable lesions, in terms of lipid-rich plaque with TECFA, macrophages, microchannels, red and white thrombus, the vulnerable plaque characteristics are indeed more frequent in these lesions as compared with the chronic stable lesions. So these lesions are like intermediate lesions between the culprit, infarct-related lesion, and the chronic stable lesions. علشان كده ما كانش مفاجأة إن for decades, I would say almost 2 decades now, investigators have been trying to prove that intervening upon these lesions during or shortly after primary PCI would improve the outcome, and it's been quite a journey, I would say. So I will start not from the very beginning of this story because it's a very long one, but Apex AMI published in 2010 can give you an impression about the landscape at that moment. The conclusion of the study read that PCI of the non-culprit lesions was performed in 10% of primary PCIs and was associated with a clear trend towards worse outcome. And the authors wrote, our data support current guideline recommendations discouraging the performance of such procedures in stable primary PCI patients. A meta-analysis published a year later covering publications from 1985 to 2010 gave the same impression, and the authors wrote, this meta-analysis supports current guidelines discouraging performance of multivessel primary PCI for STEMI. Therefore, it wasn't surprised that the 2013 guidelines recommended against PCI of the non-culprit arteries, giving it a class 3 harm. Then the game changer PRAMI trial published in 2013 was one of the first randomized trials to show an advantage of intervening upon these non-infarct related arteries, was further confirmed with a relatively smaller randomized trial in 2015. And Dynamic 3P Multi was the first sizable randomized trial proving that FFR-guided total revascularization is superior to culprit-only revascularization, was further confirmed in a larger randomized trial, Compare Acute, and I had the privilege to be among the investigators of Compare Acute, and we found that when you interrogate these non-culprit arteries or lesions during primary PCI with FFR value dictates the natural history of these lesions, and when FFR is positive, then these lesions will portend worse outcome if they are not intervened upon. This one is a mega one. Complete trial is a 4,000 patient trial from over 30 countries, published in 2019. And after accumulating evidence that FFR-guided total revascularization is the way to go, this trial took us back to the angiographic-guided revascularization, proving that even if you rely upon angiography to guide your total revascularization, you can improve the outcome. And another peculiarity of this trial is that PCI was staged in all patients, either in hospital or shortly thereafter, but within 45 days after discharge. And I'm skipping some details for the sake of time, but the trial found that whether you stage your procedure in hospital or after discharge, it doesn't matter. A meta-analysis in 2020 did confirm the advantage of total revascularization, and you can appreciate here, this is the introduction of a randomized trial published in 2021, and the introduction reads, that total revascularization is an established superior option to culprit-only lesions. This is not the conclusion, it's the introduction, the established knowledge at this stage. And the trial is flower MI, and it compares not total versus culprit only, no, it's established to undergo or to proceed to total revascularization, but whether FFR guided total revascularization versus angiographic guided revascularization is superior was the question, and both strategies were as effective as each other. So no superiority of FFR versus angiographic guided total revascularization, and this is why the guidelines is now giving a class 1 recommendation for total staged revascularization of non-culprit lesions. But what about complex multivessel disease? What about complex left main disease? These subset of patients are largely excluded from all these randomized trials. And taking complete as an example, you can see here that the syntax score of the non-culprit arteries was really small, about 5. Left main is almost not represented, and patients with true triple vessel disease represented a small minority of patients. And therefore, it's not a surprise that in many patients, you would think that CABG would be the most appropriate solution if you have a patient with multivessel disease, complex multivessel disease, or complex left main disease. However, in contemporary practice, the application of CABG to these patients is in almost 5% of cases. And I call them the remaining indications of CABG in acute myocardial infarction include after successful PCI of the primary lesion or the culprit lesion, if you have residual indication for CABG, such as complex 3-vessel disease, or when primary PCI was not possible, not feasible, not effective, or complicated. And in a very small minority of patients, you may think of CABG as the primary reperfusion strategy, and this should be reserved to cases where primary PCI is not possible and there is a large ongoing ischemia. And the fourth indication is mechanical complications, and the typical scenario is a patient who already underwent primary PCI, and then the patient is sent to the operative room to have his or her mechanical defect repaired plus minus CABG. However, if the extent of myocardial damage is extensive, such as in patients with free wall rupture or large VSR, sending the patient first to the cath lab to undergo primary PCI may not be very logical, because these hours are very precious. The priority should be given to hemodynamic stabilization and mechanical defect repair, and usually the myocardial damage is irreversible and very extensive, wouldn't benefit from putting a stent. And these 4 indications are actually represented in the revascularization guidelines, which recommend against CABG if primary PCI was unsuccessful because of no reflow. So if your primary PCI is unsuccessful because of distal disease or no reflow, then CABG is not a good ad hoc option. So when shall we, if CABG is indicated, sometimes it's really emergent, we have no choice, but if it's not that emergent, it's urgent or semi-urgent, when shall we send the patient to the operative room? Early has advantages and obvious disadvantages. And in fact, sending the patient early after MI to the operative room, it's not just that the surgeons are مش بس الجراحين ان هم بيخافوا. لا, actually there is strong evidence that early surgery after myocardial infarction portends high risk of complications, especially bleeding. Up to 50% have major bleeding, around 25% have acute kidney injury with prolonged in-hospital course. And you can appreciate from this graph how high the mortality is if the patient is sent to the operative room within hours after myocardial infarction, and the risk goes down once you wait for a couple of days, and then goes lower, even lower if you wait for around 5 days. The same applies to this very large study showing that early CABG within 2 days after acute myocardial infarction is an independent predictor of mortality, and you can appreciate that the mortality goes down by almost 50% by when you buy 24 hours, and you get the lowest mortality risk by waiting for 3 days after MI. And this very important study from West Germany shows you the so-called hybrid, because the patient in this trial, patients had already underwent primary PCI. And comparing patients who underwent CABG within 24 hours after primary PCI compared with those who were given a longer interval between the two interventions, there is a big difference in hospital adverse outcomes when we compare very early versus a little bit delayed CABG. And this very recent trial from 2022 confirms the same finding, that waiting for a couple of days would lower your mortality and also save a lot of in-hospital costs. And therefore, the guidelines strongly suggest that you buy some time. You should buy some time, as long as you can. And apart from the very, very emergent indications, you should wait for from 3 to 7 days before proceeding to CABG. And this summary, although not very contemporary, shows you that almost all societal and practice guidelines recommend that you give the patient at least 24 hours if CABG is urgent. If it's semi-urgent, then give him or her 2 to 3 days. And if you would have the luxus to wait even longer, it would be even better. This approach is an attractive one. It's a small study, but it gives you a compromise between very early CABG versus just waiting. It gives you a very dedicated pathway to bridge the patient from the primary PCI to CABG. It gives the patient the P2Y12 as always, and then transition to IV tyrofibin as a bridge to CABG. And CABG was performed on the 7th post-MI day, while aspirin was continued throughout, and the outcome was very reassuring. Very few technical considerations. We are not surgeons, but I've consulted the surgeons, and I'm referring also to the relevant publications. One of the greatest enemies of the surgeon during this situation is hemodynamic deterioration. And there is a global trend towards preemptive or prophylactic intra-aortic balloon pump, or ECMO. So even if the hemodynamics are seemingly or apparently more or less okay, many operators tend to use a very low threshold to use hemodynamic support. Type of graft, as always, arterial grafts are recommended, and one of the surgical tricks is to start bypass, then start to harvest the lima, not the other way around, in order to support the hemodynamics before proceeding to harvesting. And there is evidence that off-pump as well as beating heart CABG may be preferred in this situation. I'll finish with the contemporary outcomes of CABG after myocardial infarction, and there is a long list to tell you what is the outcome of CABG for MI, but as you can appreciate, a long list in the 80s and 90s, because this was the golden age of CABG in acute myocardial infarction. But fortunately, we had a recent publication with contemporary outcomes of urgent CABG. And you can appreciate that the application of CABG to STEMI patients is going down and down, while the complexity of the patients is rising. And you can see here on the upper side that the utility or the use of CABG in STEMI is going down over the years. However, and this is very reassuring, the mortality is improving. I'm almost done, and I need like 1 minute. And the conclusion of this very large observational studies was that utilization of CABG has decreased substantially in acute myocardial infarction admissions, especially in patients with STEMI, and despite the increase in acuity and multi-organ failure, in hospital mortality consistently decreased in this population. So my take-home messages is that total revascularization of multivessel disease in STEMI is recommended. Same session versus staged in hospital or shortly thereafter is to be individualized. If you don't have FFR in your lab, never mind. It doesn't make a big difference. CABG is underutilized in STEMI, is associated with significant risks, but outcomes are fortunately improving. Prior PCI within 24 to 48 hours or failed PCI portend worse prognosis, so try to be selective and to buy time as possible. The risk of perioperative bleeding on DAPT is increased, and discontinuation of P2Y12 inhibitors is recommended as long as you can. And if early surgery is an absolute necessity, preparedness for perioperative circulatory support is key for safety of CABG. Thank you very much for your attention.
شكرا to Mohammed for the excellent lecture actually.